So you've seen how Myofunctional Orthodontics works with some of the patients that we treat in the practice. Let's show you the appliance system and the fundamentals of using them in your practice. I studied all the functional appliances that were around for many years and found that they all had good characteristics and bad characteristics. One of the biggest issues was that they weren't really correcting function. So I designed the trainer and ultimately the MyoBrace system to primarily correct function as well as align the teeth. As I've said, the principle is getting the tongue up into the maxilla. And the main issue there is when the child is past the middle max dentition, quite often they physically cannot get the tongue in the maxilla, so we have to make it wider. And that's pretty much all the treatment that we do in our practice. And then we use the trainer and MyoBrace system to improve function, which the research has showed. And secondly, we get improved alignment. Once we move to the advanced system, we get improved alignment with the MyoBrace system. So emphasis on primarily getting good function and getting the tongue in the maxilla. And remember, it's all about growth and development. It's not about aligning the teeth. So we want the children to grow correctly. Once they grow correctly, downwards and forwards, there's plenty of room for the teeth, including the third molars. Good appliance knowledge is essential. And just to explain it simply, it really goes in age groups. We got primary, mixed, and permanent dentition appliances. Now the basic system, which is the trainer system, which I designed 20 years ago, goes in age groups. Infant trainer, 2 to 5 years of age, primary dentition. Mixed dentition, we go to the T4K, which is a two-phase system, which has a soft starting appliance and a harder appliance after 6 months to assist in aligning the teeth. Same with the T4A. In the permanent dentition, we use the T4A. Same appliance, just longer for the longer arch form, and very handy retainer appliance. So that's the basic trainer system. The adjunct now is the lip trainer, which we use for getting improved lip seal. Many children who are mouth breathers in particular still struggle to get their lips together, and the lip trainer improves the function of the bicularis oris and gets them good lip seal. So there's the basic trainer system. If you've been using this for many years, you really need to move on to the more advanced systems, which I've designed over the last 5 years. So the basics of the trainer system is that there's a tongue tag and lip bumper. This is in all our literature and also on the website, so you can see the function is really to change the tongue position to the correct position in the maxilla and discourage the overactive mentalis, and it's made in class 1 position. So this is the tongue's eye view, if you like. You can see that everything's directed towards the tongue tag, so the tongue goes up into the maxilla. And it's followed by the harder T4K, which gives improved dental alignment. Again, this is made in class 1, not edge to edge as the older appliances were. And optimum use is 6 to 8. Early mixed dentition, it'll work great by itself with good alignment improvement using the two-phase system. Once the children get into the 8 to 12, nearly always you need some extra arch development, and we use the bent Y system with that. If they're very narrow, we would use a BIBOX stage 1 before the T4K. Here are the principles, and really it's all about getting the tongue up into the maxilla. And we do that, as I said, in 2 ways. We make the child aware that this is where they should have the tongue, and the trainer assists them to get it there and stops the tongue pushing forward or sideways. So when the trainer goes in place, the tongue has to sit into the correct position. And you'll see here the correct swallow, which is basically the tongue on the spot. And as they roll back, you can see that tongue with 500 grams of force develops the maxilla. Now, if the child doesn't have the mouth closed all the time and doesn't have the tongue in the right position, that correct growth and development won't happen. So the trainer assists that. You can see when the trainer goes in place, automatically the child is told that they need to keep their lips together. And you can see by doing that, it stretches the mentalis and also forces the tongue to go into the maxilla. Basic principles of the trainer system. And our more advanced appliances, the Myobrace system, still uses the same Myofunctional system. As I said, it goes in age groups. So we start with the primary dentition. The infant trainer has, again, slightly different characteristics. Has a little air spring, 2 air springs at the back, 2 at the front. Very good for when we see malocclusion in the primary dentition, when we've got mouth breathing, young children. We want to get that tongue up into the maxilla and get them breathing through the nose. T4K, most commonly used appliance. It's used in the mixed dentition. In the later mixed dentition, we advise that you probably need some arch development prior to the T4K. And when we're using the BWS, we can use the 2 things together, which I'll show you in a moment. And then again, move to the T4A. Permanent dentition, always use the T4A. It's has a slightly different design. We like it as a retainer because it has a thinner base, but it's also very good for minor relapse or minor correction of the anteriors in the adult patient. Lip trainer, read more about this on the website. There's a video that explains how to use it. Very handy, as I said, for those children who have mouth open posture, the mouth breathers that you're finding difficult to correct. We probably use this now in about 30 or 40% of our patients. Don't introduce it to start with. Get them started on the trainer. Don't confuse the children with too many things to do. After 3 to 4 months, then go on to the lip trainer and you'll see that improves that lip seal. Now, if you've been using the trainer system for years and haven't moved on to our advanced system, now's the time. It's better to come through and use the basic trainer system first. But you see, with our advanced system, you can do a lot more things. Basic of the advanced system is using dual molded technology, which I developed some 5 or 6 years ago. So we have an inner and outer core. That allows us to do some arch expansion with the appliance and also allows us to still use a soft and flexible appliance. So the one that is most useful in the primary, late primary and early mixed is the i3. I was asked to develop a class 3 appliance and that was the i3, pretty much based on the Frankel principles. Then we move on to the I2, which is using the same sort of Frankel principle, but also giving us very good arch expansion as an additional lip bumper. And then on to the Myobrace system. Well, pretty much these are all now under the Myobrace system. So the Myobrace system incorporates the dynamic or the harder inner core. But when we use the Myobrace aligner, that's really for the late mixed dentition to align the dentition. Problem with these, you need to learn a few things. They're in multiple sizes. You have to learn when to use them and when not to use them, how to prepare the arches, and we'll show you that in the longer courses. T4A, as I said, T4A phase 2, that's pretty much our retainer these days. So there you have the system from start to finish. I'll go through these appliances individually. I brought out the Myobrace Interceptive series quite recently, due to the demand for something that's more than the T4K. It does expansion as well as the dental alignment. The class 3 appliance, we recommend that you use it early. We see a lot of early class 3s. When we start to use it, we have to tell the parents that this is your own opportunity. 5 to 7 years age is optimum. When you get to 9, 10, 11, class 3s can be quite difficult to correct because you have the discrepancies of the maxilla and the mandible are increased. The basis of the I2 was from the I3 because a lot of doctors said, well, what about class 2 corrections? You have an I2. And really, the principles are the same. Frankel said, yes, we get the oral musculature away from the the bone will grow out, and that's how he does his arch expansion. We use a dual effect of getting the tongue up there with the tongue tag, and in addition to that, we have the Frankel cage, which helps to expand the arch form. Made in two varieties, I2N and I2. N just stands for no inner core. So the starting one's soft and flexible. You'll see how we use this really well with the bent wire system. And the harder one has the inner frame, so for further arch expansion. Key feature of the Interceptive series is this tongue raising on the lower part of the appliance, and that helps to lift the tongue up. The children, when they put it in, physically feel the tongue being lifted up, and that's the key breakthrough. We're not only training the tongue to go into the right position, we're forcing it up away from the incorrect position in the mandible. Tongue tag, all the same stuff as the regular trainer, but you can see the higher Frankel sides to get the full Frankel effect. When we come to the bent wire system, this is really our standard appliance for doing arch development. Very simple appliance, easy to make, but you have to learn a few things. And then you come along to one of our courses and we'll show you how to do it. There's also a video that shows you how to use it. The advantage is there's nothing in the palate to get in the way of the tongue. Initially we use it with the T4K together, so we can do simultaneous arch development and myofunctional correction. But now, the appliance of choice is certainly the I2N. Great appliance, stays in well and works very well with the bent wire system. For arch development now, we used to use many different appliances in the practice. Arch development, if you want to use an acrylic appliance, we would say the best one is the BioBlock stage 1, because it has similar motions to the bent wire system, but we only use it really in rare occasions in the early mixed dentition when we have only short crowns. Routinely now we use the bent wire system with the I2N, and you can see the motion of the bent wire system is to develop that arch form so we can get more room for the tongue. And as I said, we use the I2N over this to simultaneously retrain the tongue into the correct position. We have a dual effect then. The tongue is actually doing what we feel is about 50% of the expansion. So if we look at the effect of the BioBlock and the BWS, they're pretty similar. The difference is that there's no encroachment on tongue space with the BWS, and also you can use the I2 or the trainer in conjunction with it. And that's the effect. The expansion that we want. We want the anterior, you can see in both cases that we want the anterior teeth to come forward because we want to develop that maxilla forward, which is the correct direction of growth. And disadvantage of any acrylic appliance, it gets in the way of the tongue. Advantage of the BWS, it doesn't. So the tongue does probably half of the expansion. So this is the effect. We're moving the anteriors forward. We're developing that arch form, and we're getting the tongue up in the maxilla. And when we take the bent wire system out, the tongue's already up there, so we no longer need to use retainers. And you'll see that those cases I showed you, where there are no retainers required, because the tongue is the best retainer. Bent wire system, a lot of doctors have an issue with learning how to bend wire, but that's all you have to do. Learn to bend wire, learn how to use this and manipulate it in the mouth. It's very simple to make. Again, this is 3D, is on the web. Come to one of our courses and we'll show you exactly how to use it. But it's a critical part of treating all cases with the Myofunctional orthodontic system. If you've got the bent wire system, you can tackle many, many cases that would not be very successful just using the trainer system. So we get the appliance made on the model, put it in the mouth with a couple of molar bands on with Farrell bent wire system tube, make a 1 to 2 millimeter adjustment every month, hold it in with linkages, that's it. Simple appliance, cheap to manufacture in your practice, and very, very effective, provided it's used with the trainer or the MyoBrace I2 system. Again, come to one of our seminars and we'll teach you more. We've got hands-on courses going on all the time. And if you're using brackets, we also have the braces series. This is the T for B, very useful. Routinely, if you're putting on braces, you want to be able to not only correct the myofunctional habits, but also it helps to stop the irritation of those brackets on the soft tissue. In our practice, we only use probably brackets in 2 to 3% of cases now, but for those who really still want to use fixed appliances, the T for B is a great routine appliance. I like the T for C2 or the T for B2, which is a thicker, more robust appliance, really good for class 2 correction while you're in braces. You can see how this one actually has a tighter fit than the regular T for B. Great for those cases you want to get in and out quickly with your brackets, and you'll find that it'll treat them much more quickly. Our MyoBrace is probably the most misunderstood appliance. It's in multiple sizes. It needs some good knowledge, and you have to know when to apply it. And you have to have reasonably good arch form, reasonable alignment. You put the MyoBrace in and you'll get better arch development, and these will really finish your cases off with our braces. Ideally, late mixed dentition. The key to the MyoBrace is the dynamic core that I developed 5 or 6 years ago. We wanted almost like arch wire inside the appliance. The dynamic core gives this great simultaneous anterior arch development along with myofunctional correction. And we also have the 2 slots, which are mean that we have to have multiple sizes, but the 2 slots also give us additional arch expansion. Here we see the MyoBrace regular and the MyoBrace N with no inner core. So really we start with the MyoBrace, the regular one with during the day, and the N with no inner core at night, and then we switch over after 3 to 4 months just with the MyoBrace regular with the dynamic core day and night. As I said, 2 slots. These have an effect like separating elastics. They push in between the teeth, and this gives you the characteristic spacing that you get with the MyoBrace, which gets additional arch length. And don't worry about the spacing, because once you get onto the retainer, the spaces will close, but very good for getting really good anterior arch form. So the 2 slots act like separating elastics and gives us a bigger arch form, and we find that we really can't get that extra large little bit of arch development without the MyoBrace. 7 sizes, you need to be able to measure them correctly, but that gives you we've eliminated the very small and the very large sizes. That gives you pretty much all the sizes you need. And this is how you measure the correct size, which is a distal lateral, and that gives you a measurement on the ruler, and then you go and get the correct size. I always say if it's a little bit more, you always go for the larger size. So if it's 3 and a bit, go for size 4. If it's 5 and a bit, go for size 6. So you always just pick one that's slightly larger when in doubt. Or additionally you can measure the size of the anteriors. What we see routinely with using the MyoBrace, and generally the MyoBrace system with the BWS, we get tremendous mid-face development. We emphasise that when you start treating these cases, you need to prepare the arch, because when you go to the MyoBrace, it's got to fit the patient. So you make sure the arch form is reasonably okay, and you'll see in this case we developed the arch form first with the bent wire system, and then before we moved on to the trainer system. So bent wire system, I2N to start, usually I2, and then we go on to the MyoBrace afterwards. So the MyoBrace gives you this tremendous development, arch development. You see the lower anteriors, they're corrected, no braces, obviously no extraction required. And we get this mid-face development, very much advanced. You can see the maxilla and the mandible have come forward. And how do we do that? We don't do it with a fancy acrylic appliance that has major forces on the teeth. We get that by the trainer and the myobrace getting the tongue up in the maxilla, and the tongue is driving the maxillary development forward, and automatically when they get their lips together, the mandible comes forward as well. So we get natural growth and development. Mid-face development, always, just about every case we see, we get really good mid-face development. Why? Because the tongue is getting up there and we've got 500 grams of force now developing the maxillary complex. So if you want a cookbook approach, here it is. Advanced system, this is what we use in our practice all the time. Start with an I2N and combine with the BWS. After 3 to 4 months, when you've got good arch form, usually we take the BWS out after 3 to 4 months anyway, and then we switch to an I2. If we need some more arch expansion after that, 3 or 4 months down the line, we might go back in with the bent wire system, but routinely 3 to 4 months with the I2N and the BWS. Take the BWS out, leave the bands on, switch to the I2, which maintains and assists the arch development and also gets the tongue right up in there. And then if we've got good arch development, now we're ready for the myobrace. We take the bands off and then we put the myobrace in. Again, myobrace end at night and the myobrace regular for 2 hours during the day. And we finish off with the, as a retainer, T4A. Don't leave the myobrace in for too long because remember it's an active appliance. It's not used as a retainer. Get the myobrace out and then use the T4A. Our newest appliance now is the myobrace for adults. We've got many requests throughout the world for an appliance that was specifically designed for adults. We never really had one. The T4A was never designed as an adult treatment appliance. So I designed the myobrace for adults, a 3-phase system. This is again all on the web, a lot of information about it. Starting with a soft appliance, moving to a medium hard appliance, and then onto a harder appliance after probably 3 to 4 months of each. Ideally, you'd use it with the bent wire system to get that the maxilla developed. Obviously, you have to be more conservative with the adult patients. So here we have also our adult education CD, which you can get from MRC. 3 appliances, and it's also a 3-level appliance system. Some patients just want something to align their teeth to make them a little bit better. Others want a movie star smile with our braces. So we can use the myobrace for adults just by itself, or we can combine it with the bent wire system or other arch expanders. Obviously we prefer the bent wire system. So that's pretty much all our appliance systems. Let's move on briefly to TMJ treatment and diagnosis.